Welcome to part 5 of the congenital heart diseases. We're going to talk about the aortic stenosis. Normally the aorta is the larger vessel in the body. Its size should be more than twice the size of the pulmonary artery, but here you find that the aortic valve is small. In aortic stenosis, there is narrowing of the aortic valve that prevents the valve from opening properly and obstructs the flow of blood from the left ventricle to the aorta. This can reduce the amount of blood that flows forward to the body. So a small aortic valve or a stenosed one will prevent the blood from flowing properly to the aorta. What are the symptoms of that child? There is fainting or weakness with activity. دايخ طول النهار، أنا دماغي كده، أنا مش قادر أقوم، أنا رجليا مش شايلاني. دي بتبقى الشكوى. ده تحس ان هو مهمد، الام تيجي تقول تحس ان هو مهمد على طول. And you have to predict that this is aortic stenosis. Breathlessness with activity. مش عارف ياخد نفس، ما بيلعبش كويس، ما تحس ان هو نفسه قصير في اللعب. Sensation of feeling the heartbeats, palpitations. Sometimes the mother comes and says, I can feel that my baby has got a rapid heart rate. Chest pain and angina type, it is under the sternum. It may radiate. It is crushing, squeezing, pressure or tightness. It increases with exercise and relieved with rest. This type of chest pain is alarming. And we have to understand that aortic stenosis may show no symptoms until late in the course of the disease. يعني كتير قوي من الأهل بيخافوا من الانترفنشن. يعرفوا إن الطفل عنده aortic stenosis. ويقعدوا يقولوا هو مش بيشتكي، نتدخل ليه؟ And we tell them, once the child starts to complain, he will run a downhill course because the patient is not complaining because of a large ventricle that is pumping blood and increasing, becoming hypertrophied and increasing the force of contractility against a closed aortic valve. There comes a time that the heart will not be able to stand all that pressure, effort, and it is going to fail. So once the symptoms start, the patient runs a downhill course, and in this particular patient, we don't have to wait for symptoms. The signs will show that the patient has got pulses, parvus. Parvus means it's a low pulse, weak pulse. Tardus means it is delayed. The blood pressure is also low blood pressure. On cardiac examination, I find that the apex is a heaving sustained apex, and I hear an ejection systolic murmur on the pulmonary, on the first aortic area. This is called the first aortic area. This second heart sound might be reduced or absent aortic component, and the ejection systolic murmur, it is and shows a crescendo decrescendo. Crescendo means it goes up and then goes down, and it is harsh. The investigations show that there is cardiomegaly with left ventricular hypertrophy, post-stenotic dilatation might be present. The ECG will show a left ventricular hypertrophy because it is the aorta that is closed with the left ventricle putting much effort to pump blood, and the echo is diagnostic in such cases. The complications include left ventricular hypertrophy caused by the extra work of pushing blood through the narrowed valve, left-sided heart failure, arrhythmias and sudden death. So in these patients we have to avoid strenuous exercise, endocarditis and valve infection and valve calcification later on. The treatment by anti-failure measures, although we don't have to reach this stage, infective endocarditis prophylaxis, intervention by valvuloplasty by catheter, or surgical treatment of the condition. Pulmonary stenosis. Pulmonary valve is narrowed and caused obstruction to flow from the right ventricle to the pulmonary circulation. In this case, the clinical picture in most cases when it is not that severe, the patients are asymptomatic and may be accidentally discovered. A critical PS it shows that there is severe pulmonary stenosis that presents in the neonatal period in the first few days of life with duct-dependent pulmonary blood flow and cyanosis. In the critical PS, that's an acute condition, and in the neonatal period, you have to interfere because the patient is depending on the duct that might close later on in life in the first few days of life. The physical signs show that there is an ejection systolic murmur on the second or third left intercostal spaces. This again is a crescendo-decrescendo murmur. It's a harsh murmur like that of aortic stenosis, but it is present on the right and the left side of the precordium at the pulmonary area, while the aortic stenosis, the murmur is heard over the left side, and it is on the first aortic area, and it is frequently accompanied by a thrill. Both of them might be accompanied by a thrill. In this case, pulmonary stenosis might be accompanied by injection click. The chest X-ray might show a post-stenotic dilatation of the pulmonary artery. The ECG shows a right ventricular hypertrophy, and the echo is diagnostic and demonstrates the valve affection and the right ventricular hypertrophy. The management includes prophylaxis against infective endocarditis. In severe stenosis with marked right ventricular hypertrophy, transvenous balloon dilatation of the pulmonary valve is indicated or surgery, so you have to interfere in severe cases. Coarctation of the aorta. Coarctation of the aorta is frequently missed because it is not a routine for everybody to palpate the peripheral pulses, and that is why coarctation of the aorta, I start by saying please palpate the femoral arteries. Why? What is coarctation? Let's see what's coarctation. Coarctation is an obstruction in the aorta, as you see here around the circle here in the right side of the figure. You see there is constriction in the aorta, so that the patient will be having high blood pressure before the point of coarctation and a low blood pressure beyond the point of coarctation. So the patient will be having hypertension, and at the same time he might be having poor renal perfusion. It is often associated with other cardiac anomalies, especially bicuspid aortic valve and the VSD. The key to the clinical diagnosis of coarctation of the aorta is the recognition of a weak or absent femoral pulses. So routinely we have to palpate the femoral pulses in every patient. The symptoms vary. In the neonatal period, if severe coarctation, there is sudden circulatory collapse on closure of the PDA and severe heart failure. In older children, they present with hypertension. On physical examination, we find weak femoral pulse, or what is called radiofemoral delay, that the femoral artery is felt after the radial artery. Blood pressure in the lower limbs is lower than that in the upper limbs, and that is not the normal, because normally we all of us have blood pressure that is higher in the lower limbs than the upper limbs by 10 to 15 millimeters mercury, and in this case now we have the blood pressure in the upper limbs higher than the lower limbs. The murmur might be heard over the back between the scapula due to the presence of collaterals, and this is present in older children. The chest X-ray may show cardiomegaly and increased bronchovascular markings in the presence of heart failure. Rib notching, this is notching in the lower parts of the rib, might be seen in older children due to dilated collateral arteries. The ECG shows left ventricular hypertrophy, and if you remember, we said that the VSD, the aortic stenosis also show left ventricular hypertrophy, and the echo is diagnostic in such cases. Management is by surgery or transcatheter dilatation and stent application. Please be ready with your questions in the next face-to-face sessions about this part. For further readings or listening to murmurs, please look at these sites. And to have a kind heart, have a kind heart to be a good doctor, and good luck with the acyanotic heart.